Welcome to the module on oxygen therapy and nasal cannula and face masks. This module is part of the WHO COVID-19 Clinical Management course series. At the end of this module, you will be able to explain the role for oxygen therapy for patients with COVID-19, describe the role of pulse oximetry to measure blood oxygen levels, describe indications for oxygen therapy, explain how to initiate oxygen therapy via nasal cannula and face masks, and finally explain how to titrate oxygen therapy delivered via nasal cannula and face masks. WHO has developed several manuals and guidelines describing oxygen therapy. These are available online at the main WHO website. For decades, WHO has considered that effective oxygen delivery should be a universal standard of care and should be made more widely available. Oxygen is considered an essential medicine and is listed on the WHO Essential Medicine lists. Hypoxemia is a life-threatening condition that can be easily treated with oxygen therapy. Oxygen therapy saves lives. Oxygen therapy is an essential medicine that should be available in all clinical areas that may care for patients with COVID-19. Of COVID-19 patients who are asymptomatic, approximately 15 develop severe disease requiring oxygen, and 5% develop critical care, with complications including respiratory failure. Many of these patients can be treated with oxygen by nasal cannula or face masks and good quality supportive care. Investing in oxygen therapy can save thousands of lives. WHO provides tools and guidance to help countries prepare for and respond to COVID-19, including scaling up oxygen delivery systems. Visit the links on this slide. Oxygen is critical to proper function of human body. Organs and tissues require oxygen to function normally. Example, the brain, the heart, kidneys, liver, and intestines. When there is lack of oxygen, it quickly leads to organ dysfunction and death. The process of breathing or respiration is the process by which oxygen is taken in and carbon dioxide is released from the body. Difficulty breathing is a life-threatening condition and may occur in patients with COVID-19. The air we breathe is composed of many gases, and oxygen makes up 21% of it. Under normal conditions, when a person inhales, air travels down the trachea into the lungs. That is how the air that is breathed delivers oxygen to the lungs. Once in the lungs, oxygen crosses the alveolar membrane of the lung and enters the blood. 98% of the oxygen binds to hemoglobin on the red blood cells, while 2% of oxygen remains unbound in the plasma. Hemoglobin carries oxygen throughout the body to the cells and tissues that use oxygen to function. There are many definitions about oxygenation that are important to understand and differentiate, as they will be mentioned several times in the following training materials. Hypoxemia. Hypoxemia means there are low levels of oxygen in blood, and that can be a life-threatening condition. Hypoxia. Hypoxia means low oxygen in the tissues and organs in the body, and it is a consequence of hypoxemia. FiO2. FiO2 is the fraction of inspired oxygen, like the percentage of oxygen in the air the patient is breathing. In the normal air at sea level, the FiO2 is 0.21 or 21%. This FiO2 increases when supplementary oxygen is given. The amount of increase in FiO2 by various modalities of oxygen delivery depends on many factors, such as the size of the patient's breath, the breathing rate, the inspiratory flow rate, and the type of tubing involved. For example, it is generally accepted that when a patient is given 4 liters per minute of oxygen through a standard nasal cannula, the FiO2 increases to approximately 0.36 or 36%. PaO2 represents the partial pressure of oxygen in arterial blood and reflects how well oxygen is able to cross the lungs into the blood. A low PaO2 reflects hypoxemia. SaO2 is the arterial oxygen saturation and is measured through an invasive technique, the arterial blood analysis, also called arterial blood gases. SpO2 is the arterial oxygen saturation and is measured by pulse oximetry. The SpO2 is a non-invasive and accessible measurement of oxygen and used frequently in the clinical setting. Therefore, the SpO2 is often used to identify hypoxemia in the clinical setting. It is important to recognize that pulse oximetry can overestimate the oxygen saturation in patients with darker skin, usually by approximately 2 percentage points. This is particularly important in patients with borderline oxygen saturations. For example, a patient with a true SpO2 of 88% might have a reading of 90%. Clinicians must use their judgment in interpreting borderline oxygen saturations and should monitor patients closely for trends in clinical status, including in the SpO2. When in doubt, clinicians should err on the side of conservative management of disease classification. This is the hemoglobin-oxygen dissociation curve. It shows the relationship between the oxygen saturation of hemoglobin on the y-axis with the partial pressure of oxygen in the blood on the x-axis. The dissociation curve has a sigmoid shape related to the affinity of the hemoglobin for the oxygen. More oxygen molecules bind as the oxygen partial pressure increases until the maximum amount that can be bound is reached. The tendency for hemoglobin to bind oxygen decreases as the hemoglobin molecules become saturated. On the flat part of the curve, where SaO2 under SpO2 is greater than 90%, very little additional binding occurs and the hemoglobin becomes saturated with oxygen. Meanwhile, on the steep part of the curve, when the SpO2 is below 90%, small changes in PaO2 will result in dangerous falls in SaO2. This all means that the SpO2 of a patient may decrease slowly from 100 to 90%, then it will begin to fall rapidly once it goes below 90%. Therefore, the importance of oxygen therapy is based in that hypoxemia is a life-threatening condition that can be easily treated when oxygen is available. Oxygen therapy saves lives. All health facility areas that may care for severe COVID-19 patients should be equipped with functioning oxygen systems, such as oxygen concentration cylinders, PSA, disposable single-use oxygen delivering interfaces, such as nasal cannulas and different types of masks, and pulse oximeters to monitor the response. This includes the pre-hospital setting, primary care outpatient clinics, emergency units, critical care units, and ad hoc community facilities that may receive severe patients. Medical oxygen may be delivered by different systems. Oxygen tanks or cylinders can provide high flow of oxygen. Oxygen concentrators can deliver ranges from 2 to 10 liters, or piped central oxygen delivery systems such as oxygen plant or liquid oxygen can deliver high flow oxygen. It is important to know what type of system your facility has, how to use it, and how to increase the supply according to demands. There are different oxygen delivery interfaces available. The most simple and available ones are nasal cannula, commonly known as Bronx, Venturi face masks, and masks with reservoir bags. SpO2 measurement via pulse oximetry is often used to define hypoxemia in the clinical setting. Hypoxemia can also be detected clinically by doing a physical assessment of the patient and evaluating for signs such as cyanosis. However, in patients with COVID-19, clinical signs alone are not reliable indicators of hypoxemia. Pulse oximetry should be performed on all patients with severe acute respiratory illness, SARI, including COVID-19, either as continuous monitoring or as spot checks in screening or triage areas. Home pulse oximetry monitoring may be considered for patients with mild and moderate COVID-19, depending on the clinical situation. Pulse oximetry monitoring measures the saturation of the hemoglobin in the blood, SpO2, and has several advantages. It is non-invasive compared to blood gases tests, can measure the pulsatile flow, and additionally can give the heart rate. A variety of styles and types of pulse oximetry devices are in use around the world as pictured here. For example, a fingertip pulse oximeter, a handheld pulse oximeter, or a tabletop pulse oximeter. Know what type or style of pulse oximetry device you have at your facility and how to use it. To know how to interpret the pulse oximetry, you must know that it normally displays the saturation of oxygen, the heart rate, and the arterial tracing or pulse wave. For example, in this illustration, you can see a pulse oximeter accurately giving a normal reading, the SpO2 of 97%, the heart rate of 102, and the smooth pulsatile strokes of arterial tracing or pulse wave are consistent with an accurate SpO2 reading. In these other examples, you can see variations in the display of pulse oximeters. For example, in the pulse oximeter on the left, the reading of saturation of oxygen is 82% with a good pulse wave. Being able to identify a consistent wave means that the device is detecting the real pulse and the reading of 82% is accurate. Additionally, it shows the patient as tachycardia with a heart rate of 150. In the example pulse oximetry on the right, the wave is irregular. This raises concerns that the device is not detecting accurately and that the reading of 83% oxygen saturation may not be correct. There are many factors that can cause a poor wave. The patient is moving, the electrodes are not sensing well due to poor placement, artificial nails or nail polish, or there is a poor perfusion or shock. Oxygen should be administered immediately to any adult or child with respiratory distress, sepsis with hypoperfusion or shock, or with alteration of mental status. If hypoxemia exists, we should give oxygen when the saturation is less than 90% in hemodynamically stable patients, at a saturation below 94% if the patient has an emergency signs with or without respiratory distress. And emergency signs include obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, and/or convulsions. Patients with emergency signs may require airway management in addition to oxygen administration. Remember that in pregnant women, oxygen therapy must be started whenever the saturation goes below 90 to 95%. Do not delay giving oxygen. In children, when a pulse oximeter is not available, there are some clinical signs that should trigger the clinician to start oxygen therapy. These include the identification of central cyanosis, nasal flaring, inability to drink or feed because of respiratory distress, grunting with every breath or head nodding, depressed mental state like children who are drowsy or lethargic, severe lower chest withdrawing and/or fast breathing with a respiratory rate above 70 breaths per minute. Do not delay giving oxygen. Once oxygen therapy is started, closely monitor the patient to make sure that the goals of optimal oxygen are met. Titrate oxygen to target the best SpO2 for the patient and optimize oxygen therapy. Generally, for adults and children, oxygen should be given to achieve an SpO2 greater than or equal to 90%. In pregnant women, the goal must be a bit higher, reaching a SpO2 around 90 to 95%. If the child or adult present with signs of multiple organ failure, including shock, alteration of mental status, severe anemia, or during resuscitation, our target must be more than 94%. Once the patient is stabilized, you can resume the target of SpO2 above 90. It is important to titrate oxygen up and down to achieve these targets and wean oxygen when possible. When delivering oxygen, it is important to use the appropriate delivery device for the dose of oxygen given. A nasal cannula allows us to administer a dose between 1 and 5 liters per minute with an FiO2 between 0.25 to 0.40. If more flow is needed, the next step would be changing into a Venturi mask that will allow us to administer between 6 and 10 liters per minute with an FiO2 between 0.44 to 0.6. But if the patient is in respiratory distress and needs to increase the amount of oxygen administered, we can achieve doses between 10 and 15 liters per minute and FiO2 between 0.6 and 0.95 with a face mask with a reservoir bag. When using a face mask with a reservoir bag, make sure that the bag is filled with oxygen. An empty bag can asphyxiate the patient. Different equipment can be used to produce and deliver oxygen. Depending on the device, different flows of oxygen can be delivered to the patient. Concentrators or cylinders can be used as a portable oxygen source if piped oxygen is not available. Concentrators only allow small flows to be given to the patient. Most concentrator models go from 2 liters to 10 liters. You should always check the capacity of the device you have in your facility. Therefore, nasal cannula and Venturi face masks should be used with concentrators. When cylinders or pipeline oxygen you can use all the spectrum of devices, but if the need is above 10 liters of 10 liters of oxygen, only a non-rebreathable mask or a mask with a reservoir bag should be used. Oxygen flows over 4 liters must be moisturized through humidification. Some devices also add worms to the air. At low flows, below 4 liters per minute, the nose and pharynx provide adequate natural moisture and humidification is not required. But oxygen delivered at higher flow without humidification can dry the nasal mucosa and can cause bleeding. Higher flows also can dry secretions, potentially leading to an airway obstruction and may cause bronchoconstrictions in some conditions such as asthma and COPD. Therefore, you must remember to have an humidifier attached to the oxygen device when flows is higher than 4 liters are required. This slide illustrates the algorithm of oxygen administration in adults. You should start with oxygen at 5 liters per minute using nasal prongs and assess the response. If the respiratory distress does not improve, increases, or SpO2 remains below 90% despite nasal administration, you should consider changing the device to a face mask and increasing the flow to 6 to 10 liters. Always secure the face mask firmly to the face or the nose and make sure it is well fixed. If despite this the patient is still in distress or the target of SpO2 is above 90% has not been reached, consider changing to a face mask with reservoir or to deliver a flow between 10 to 15 liters. Make sure that the bag is always inflated to be able to deliver the highest oxygen concentration. An empty bag can asphyxiate the patient with hypoxia. If the patient continues to have respiratory distress is increasing, or SpO2 remains below 90% on 15 liters, further clinical management decisions should be made based on individual patient characteristics, local resources, and expertise. Call for help early for these patients. If severe hypoxemia persists despite maximal oxygen flow rates, first check that the oxygen delivery is adequate. For example, check that the oxygen is flowing, the tubing is not leaking, the prongs and the face mask fit, and the oxygen delivery system is functioning correctly. Next, consider alternate possible causes of hypoxemia that require treatment specific to the condition, in addition to oxygen, such as bronchospasm in asthma and COPD, heart failure, pleural effusion, pneumothorax, pericardial effusion, acute airway obstruction, and shock. Review the initial approach to the patient with a difficulty in breathing module, with Open WHO course series, and the WHO ICRC Basic Emergency Care. For adults with worsening hypoxemia despite appropriate oxygen therapy, it is important to confirm that the airway is clear. Airway clearance techniques may assist the secretion clearance for adults with increased production of secretions, retention of respiratory secretions, and/or a weak cough. These patients may not be able to clear their respiratory tracts independently. Airway clearance techniques include gravity-assisted drainage and active cycles of breathing technique. Avoid mechanical insufflation-exsufflation and inspiratory positive pressure breathing. Implement techniques based on the individual patient and follow available guidelines. Another factor to consider in an adult with worsening of the hypoxemia despite oxygen therapy is positioning. A correct positioning may help optimize oxygenation and decrease work of breathing. Consider raising the head of the bed so that the patient is in a high supported sitting position, sitting as close to upright as possible. Prone positioning in awake, spontaneous breathing patients may improve hypoxemia, but evidence is lacking and should be done under clinical trial protocol to assess efficacy and safety. If despite all these considerations the patient continues to have worsening respiratory distress and the SpO2 is persistently below 90% on maximal oxygen flow by optimal delivery system, fitted face mask with reservoir bag, further clinical management decisions should be based on individual patient characteristics as well as local resources and expertise. Start considering next steps, including non-invasive ventilation, high-flow nasal oxygen, or even invasive mechanical ventilation. The advanced respiratory support modules have more information on these therapies. Do not delay intubation if there are urgent indications. Respiratory failure can be rapidly progressive. Closely monitor COVID-19 patients for signs of respiratory deterioration. Respiratory failure may be rapidly progressive in these patients. Be ready to respond immediately with supportive care interventions. In the next few slides, we will discuss special considerations in pediatrics. For infants and children below 5 years of age, nasal prongs are the preferred method to deliver oxygen. Make sure that the size of the cannula is the appropriate for the child. The distal prong should fit well into the nostril. The prongs can be secured with some piece of tape to avoid misplacement. Make sure the nostrils are clear of mucus. Remember to humidify oxygen delivery rates above 4 liters per minute. Always monitor with pulse oximetry during oxygen therapy. In children, the indications to start oxygen therapy are when the child presents with respiratory distress and SpO2 is below 90%. If the child shows any emergency sign, with or without respiratory distress, start oxygen for an SpO2 below 94%. If pulse oximetry is not available, oxygen therapy should be started as soon as any clinical sign of respiratory distress is identified. The oxygen flow to be given must be adjusted to age. For example, in neonates, the flow should not exceed 1 liter per minute, but in preschool and or school-age children, we can go until 4 liters or 6 liters respectively. Always titrate oxygen to maintain SpO2 of 94% or more during resuscitation. Once stable, maintain an SpO2 above 90%. In children, if severe hypoxemia persists despite maximal flow rates of oxygen, check that the oxygen delivery is adequate. Check that the oxygen is flowing, the tubing is not leaking, the prongs fit correctly, and that the delivery system is functioning correctly. Consider alternate possible causes of difficulty in breathing, such as upper airway obstruction, croup, shocking, bronchospasm, if it is present asthma, heart failure, and pleural effusion. If the child is still hypoxic, start CPAP or high-flow nasal oxygen if available. Start a secondary source of oxygen, adding a face mask with reservoir bag to the nasal cannula if possible. If the child continues to be severely hypoxemic, consider intubation with mechanical ventilation if available. In summary, give oxygen to patients with difficulty in breathing, signs of hypoperfusion or shock, alterations of mental status, emergency signs, and SpO2 below 90%. Oxygen systems, delivery interfaces and pulse oximeters should be available in all health facilities that may care for COVID-19 patients. For procurement, see Emergency Global Supply Chain Systems Catalog. WHO is developing additional guidance and training on equipment use. These will be available on the website. Titrate oxygen to target using appropriate delivery flow and interface. Target an SpO2 above 90% in adults and children who are stabilized. Target an SpO2 between 92 and 95% in pregnant females. Target an SpO2 above 94% in adults or children with emergency signs. Listed here are some additional resources for patient care and guidance for oxygen therapy. Thank you for listening.